Click.
Okay, good morning, everyone, and welcome to our October Commission meeting. I am Valerie Sullivan. I am chair, and I am joined here by other commissioners, and I am going to turn it over to Andrew to do roll call / list out which commissioners are here with us today. Thanks, Andrew.
Thank you, Madam Chair. With us today, we are joined by Commissioners Bobby Kaplan, Designee Cassandra Roder, Designee Rebecca Butler, Commissioner Elizabeth Shabbat,
Here.
Commissioner Adam Chapdelaine, Commissioner Choate, Commissioner Christy Clenard, Commissioner Tamara Davis, Commissioner Jane Edmonds, Commissioner Joseph Gentile, Commissioner Gersino Gerard, Commissioner Anna Sinenko, and Commissioner Timothy Sullivan.
Thanks, Andrew. I do know we have a couple of commissioners who may be joining us a little bit later, Eileen McAnamy and Patty Jennings. I think at this point, what would be helpful is for you, Matt, our executive director, to review today's agenda and give us a roadmap of what we'll be doing today at this commission meeting.
Thank you, Madam Chair. Thank you, members of the commission, members of the public joining by YouTube, and GIC staff. We have a busy day today, but a short agenda with two big items on it. In addition to reviewing our minutes and taking questions on the executive director's report, we move right into a presentation and a vote for our flexible spending account vendor at the end of this procurement, and then move on to our medical benefit procurement vote, presentation and vote for FY24. And that is the agenda for today.
Yes, I know the staff has been incredibly hardworking getting us to this point where we have some exciting new information about the medical benefits as well as FSA. So thank you. At this point, I'd like to ask if any of the commissioners have reviewed the minutes from our September meeting, and if we can either discuss or move for a motion to approve.
So moved. Second.
Okay. All right, great. So at this point, I'd like to ask Andrew to do roll call on a vote. I'm yay on the minutes.
Thank you.
Yay. Oh, sorry.
Commissioner Vice Chair Kaplan.
Yay.
Thank you. Designee Roder.
I'll abstain.
Designee Butler.
Yay.
Commissioner Shabbat.
Yes.
Commissioner Chapdelaine.
Yes.
Commissioner Choate.
Yes.
Commissioner Clenard.
Yes.
Commissioner Davis.
Yay.
Commissioner Edmonds.
Yes.
Commissioner Gentile.
Yes.
Commissioner Guerin.
Abstain because I did finish the meeting last time.
Okay. Commissioner Sinenko
Yes.
and Commissioner Sullivan.
Yes.
The motion passes.
Oh, terrific. Well, thanks, everyone. So Matt, the meeting is yours. Let's get into the meat of the meeting.
Great. We can move to the next slide. So in the interest of time and the relative lightness of material in the written executive director's report, rather than touch on specific items, I'm happy to take any questions that commissioners may have.
The only thing I thought the commissioners might want to hear very, very briefly about is how our new IT support is going. If there's any issues, just maybe a briefing on that, since it's so important to everything that's done within the organization.
Yeah, I'm happy to say that the work it continues without interruption, and it's all going very well in terms of our IT modernization program. As folks may know, we are in the last year of a multi-phase modernization of our systems. And Paul Murphy, our Director of Operations, Stephanie Sutliff, our new Head of IT for the GIC, and their teams are working closely with our vendor. And a lot of the focus of the work for this remaining year is to continue to roll out to our roll out our member services portal to our retiree members and a variety of offline agencies. And an important element of this last phase also is to build out the capabilities for a much more active enrollment for our health benefits in the future. We've had a great deal of success with the portal. I'm very encouraged by the level of our membership logging in and registering and using it. It's been especially helpful for new employees as they get onboarded. We have a very high success rate with them logging into the portal, making all of their benefit selections as they join employment with the Commonwealth or any of our partner agencies. So that work is actually going along very well, very smoothly. We've reported on this a few times, even just a few months ago, I think, at the commission, and we'll be happy to come back at a future commission and provide a more thorough briefing.
All right. Well, thank you. Appreciate that. And happy to hear that the continuity has continued. I think it's a tribute to your leadership and the leadership of all the staff. So thank you.
Thank you, Madam Chair. Vice Chair Kaplan has a question.
Yeah, so just first of all, kudos to the IT staff, because I've heard nothing but praise for the My GIC link and the sort of sorry.
I think your dog is praising us too. That's good.
Well, we'll have to forget it probably, but I just wanted to ask you about East Bridgewater. If there was any indication that they were going to leave GIC, isn't it December 1st? They have to notify us for.
Yeah, so what we know today is that they have requested data to evaluate their position and to evaluate options outside of the GIC. As I think we've mentioned, as Mike Berry presented in the last discussion on this topic, this is a fairly routine occurrence for our municipalities. And so I wouldn't take that as an indication either way, whether they intend to leave or intend to stay. I would put it into the category of our municipalities doing their due diligence about options that they have here and in the rest of the marketplace.
Thank you. That's reassuring. And sorry, I apologize. Sorry.
So,
and as you noted, sorry to interrupt, Madam Chair, Madam Vice Chair, we will be back, as you noted, at our December meeting for a thorough update on the municipal portfolio after the December 1st deadline for them to indicate their intentions to us.
Thank you.
All right, well, let's move on, Matt. I don't see any other questions, and appreciate all the work the staff has been doing for the day jobs as well as this procurement that we're all eager to learn more about.
Thank you, Madam Chair. We can move on to the calendar. Just a brief review here. As you know, our team has been and continues to be very busy working on a large volume of procurements this season. to bring to you for presentation and for your approval and votes. In November, at our next meeting, we will vote on our EAP procurement, vendor selection, and also have our annual presentation from our colleagues, David Seltz and others at the Health Policy Commission. In advance of that, I encourage commissioners to review the annual cost trends report. We'll be sure to circulate that to commissioners in advance of the meeting. So we really look forward to that. We will also have a discussion about a municipal bulletin that the staff has been working on. And then in December, we will have the vote on our PBM vendor selection, as well as a discussion of our preliminary rates for fiscal year 2024. We will also have our annual stewardship report after we have our meetings with our vendors over the next several months, and the municipal update that I already referenced. So we have a busy few months ahead. For the next meeting, I anticipate that we'll have a calendar that begins to lay out meetings that include calendar year 2023. Any questions on the calendar?
I'm sure you're already thinking about the listening sessions and when they'll be and how you're structuring them. So we're not looking beyond 22, but in January and February of 23, just curious on, thinking on dates. I know my colleague Tim Sullivan always likes to make sure that we have plenty of notice for those teachers. So the sooner the dates are out, the better.
Yeah, Erica and her team have been working on the listening sessions that will, as they are, always feature as an important element for us to update our members, particularly this year with the changes that we'll be discussing here today, but also plan design and preliminary rates as we always do.
Okay.
Erica, did you want to add anything more to that?
Sure. We're looking at the week of January 23rd to get those on the calendar. And the rest of the team will be prepared to get them up and running as we have done in years past.
All right. I don't see any other questions, so you can keep moving. That's good. Thanks
Great.
for the work on that, Erica.
Thank you, Madam Chair. And at this point, I'd like to hand it over to Cameron McBean, our Health and Ancillary Benefits Manager, to walk through a presentation on our flexible spending account vendor procurement. Cameron?
Thank you, Matt. Thank you, commissioners. Hopefully everyone has had a chance to review the recommendation memo that was submitted to the commission in advance of today's meeting. Before we dive into the results of the procurement, wanted to just refresh everyone's memory. Our current vendor for our FSA plans is Benefit Strategies. The procurement was wrapped up in August. We only had 2 vendors bid on the program, although a number of major vendors we know were notified through combis. So as part of the process, the other bidder that we evaluated was a company called Total Administrative Services Corporation.
Okay.
And I'm sorry, was there a question? No, okay. And as a result of the procurement, we are actually recommending going with this new vendor, which we refer to as Task. They are very well experienced in the public sector, including having the Federal Office of Personnel Management as a client. So they are accustomed to working with state governments similar to the GIC, as well as the federal government's almost 1 million eligible employees. So we have high confidence that they will be able to handle our population appropriately, including the challenges of working with all of our offline agencies. The two finalist scores came in very close. And so at this point, before we proceed to the vote, wanted to see if any of the commissioners have any questions about this procurement. Vice Chair Kaplan?
Yes, thank you, Cameron. I have a couple of questions. So regarding, first of all, as I recall, I think is it unusual to only have two bidders? It's just.
It is
Or would-
somewhat unusual, but it may have been, I suspect, the fact that we provided information on what the current per member per month administrative fee that is associated with participation in the FSA accounts. We were getting a very good deal from Benefit Strategies, and that is critical in that at the current point in time, the state does not contribute anything towards these fees. Now, most employers who are most plan sponsors of FSA plans are themselves the employer. And so by reducing the taxable income, there are tax savings for the employer that are realized by employees reducing their taxable income and participating in these plans. So it is usually in the employer's interest to fund these themselves. That arrangement is not in place currently with the Commonwealth. So since this is an employer-funded or employee-funded program, that we are currently offsetting those fees out of the forfeiture account, which we are going to continue to do so that even though we have a slightly higher administrative fee under the new proposed contract with Task, the cost to the participants will remain at $1 per month. But my suspicion is that letting potential bidders know what our price point was may have made us a less attractive client. But I do know that, according to what we could see in the Combis procurement platform, that all the major players that I'm familiar with in the marketplace, such as WageWorks or Discovery Benefits, they were all notified that this procurement was going to be available.
Okay, thank you. So obviously you've got, references regarding Task, but could you tell me, like, what is their customer service, if they've had, a lot of complaints, or do you have any idea about pretty much their, let's say customer service? I know that they're available on Saturdays, which is a plus, but their responsiveness, their willingness to help employees. Can you speak a little bit about that?
The references came back with excellent feedback, and based on the materials that were submitted as part of their technical proposal, as well as during the interview process, we do not have any significant concerns on the customer service front.
All right, so let me ask you this. How Benefit Strategies, that basically sort of employee driven. In other words, the employee has to log on or open the app to find out, what their balances are, if they are required to provide documentation. How does Task operate? In other words, do they reach out to the employee to say, you need to provide documentation?
Yes.
So, hey, Bobby,
Yes.
1 second, Cameron, I'm sorry. I thought there was just a little bit more discussion on this before we go into questions. Was there one more slide here? Or is
No.
this?
No, this
So
is the next slide, I believe, we can advance one just because I don't have it queued up myself, but I believe the next slide would be the vote. Oh, yes.
Yeah,
Thank
so let's just go through this slide, Bobby. Clearly, you've done your homework, and I appreciate that. Just to orient the rest of the commissioners
Okay.
to task, why don't you tell us a little bit about the process, how you selected task, how, to Bobby's point, what's going to be the transition, if we do approve this recommendation. So just if you wouldn't mind, Cameron, taking us through this, or whoever is able to do so, I think it would be helpful.
Sure thing. Yeah, there was not a wide gulf between the two bidders. Task essentially provided overall better responses through every phase of the process. We have the initial scoring phase, which incorporates supplier diversity, the written technical proposal, the essay questions, and then the cost proposal. Supplier diversity always counts for 25% of procurement evaluation under state law. And when it came to the written responses as well as the interviews, task just came through a little bit more impressive on almost every metric that we evaluated. There are a couple of functionalities associated with their debit card program that may or may not add value for some participants, particularly if we have any employees who may be what is referred to as underbanked, in that it could function as their FSA card has the capability to function as a prepaid debit card.
Cameron,
and again,
could you repeat that?
Sure. They have their FSA debit card, which can be used for both medical expenses or dependent care expenses, can also function as a prepaid debit card, in that you could have, money that you use for your FSA plans, you could have it if you used a different funding mechanism, that money, when it is reimbursed to you, could be loaded as an available balance on your FSA card, and then you could use that for whatever expenses you may wish, not necessarily FSA qualifying ones.
So I'm not sure exactly. You mean
It's
for like pharmaceutical benefits or like over the counter? Is that what you mean?
Okay, for an example, their FSA card with this additional functionality, say you go to the doctor and you have to pay a $60 copay. You do that not using your FSA card, you use your regular debit card or a credit card. You submit that claim, it gets reimbursed. It can be loaded onto your FSA card's balance. And so then if you go to the drugstore, you get your prescriptions, but you also get some other items that are not FSA qualified. You could use that card, and it has an automatic adjudication system where you can pay for the entire purchase, and only the FSA qualifying items will be automatically drafted against your remaining FSA balance. Does that make it clear?
It's a little more clear.
Okay.
Yes, but how is that going to be communicated to people? That's, it's an entirely new concept.
Yep. It will be well spelled out within the FSA handbook. We will obviously be doing a complete rewrite of that. The enrollment process will be, essentially the same as currently, just with a new website and a new app available for members who wish to enroll.
Yeah, that sounds pretty innovative. And you did reference checks?
Yes, ma'am.
Okay.
And what was the, so I'll go back to my question regarding notification or communication around, let's say balances, or whether people need documentation, because with benefit strategies, basically I had to log in. I'm just speaking about myself and other people that you had to check because there was no notice, which, you know, oftentimes they had notified me twice. I wasn't even aware of it unless you pay attention. So I think it would be a lot easier if the vendor, you know, notified the employee, basically.
Well, Benefit Strategies does. Do you not receive emails regarding your account?
No, I do not. I have to check myself. I use the app and I check it. I don't receive any, nor do I receive regular mail from them.
Okay, it sounds like there may be some inaccurate information in your account, because you should be receiving regular email updates, especially with any questions, concerns, or over the status of your account. That's an automated process with Benefit Strategies. And I'd be happy to circle back and work with you offline about this, should you wish, Mr. Kaplan.
Thank you for that, but you know, it's been like 5 years, so I'm used to checking it now. That's okay. We don't have that much longer with them, so it's fine, but I appreciate that.
Okay. Any other questions?
I don't see any here, Cameron.
Okay. With that, I believe we can move to the next slide, and I will turn things back over to Andrew.
Can I just ask one more question?
Sure,
Which
Bobby.
is how many states, state, you know, government or state employees, as opposed to federal? Like how many?
I'm sorry,
do
you
they,
asking
how many are
how
they
many
the vendor for? How many states do they work with? Do you know?
I do not know off the top of my head. I know I'm fairly certain I recall at least 3 being mentioned in the literature that was submitted in their written proposals.
So are they do you recall if they're like similar size or similar number of employees?
I believe the state of Virginia was one, so that would be significantly larger than the Massachusetts populace.
Okay. All right. Thank you.
Okay. Well, so at this point, the discussion is good. I don't see any other questions from commissioners. Thank you, Bobby, for that dialogue. At this point, then, I'll entertain a motion to approve the GIC selection of TASK, Total Administrative Services Corp., although I think TASK is easier to say, as the apparent successful bidder, assuming successful contracting to provide the FSA admin services for FY 2024. Do I have a motion? Yeah.
No,
go ahead, Bobby.
I actually have another question regarding the transition and the cards, Cameron. So when we finish or when we complete our contracts, when Benefit Strategies contract ends in June, and we have 2.5 months more, right, to submit claims for FY23.
Yep.
That means that people will have basically 2 cards, right? One for TASK, one for Benefit Strategies. And I, you know, anticipate that there will be some, you know, sort of overlap or errors where people will be submitting claims to the wrong vendor, or, you know, they're going to have 2 separate balances, right?
Correct.
So I'm assuming they've done this before with,
yes, they have,
right?
Yeah.
With those 3 states. And it sort of is, you know, a little concerning how that's going to work, because in general, there are some, you know, it happens all the time where people submit the wrong, you know, claims for the wrong fiscal year. And so I'm very curious about how that transition period is going to be communicated, because by using the same vendor like Benefit Strategies, if you submit, they just use your current balance. or your prior year balance. And it
Yeah,
goes,
so hey,
it's pretty
Bobby.
smooth, yeah, so yes.
Yeah, I think we're not at the implementation phase, but your points are, important. Andrew has his hand up. I'm
Yeah.
thinking he's got some guidance for us.
Yes, if you recall, Commissioner Kaplan, when last procurement, it was also a transition. And as part of the implementation plan, the funds were rolled from one vendor to the other to prevent the problem that you're anticipating. I'm sure that as we work through the implementation plan on this, we will be able to accommodate it. But we haven't voted for the vendor, so we don't have an implementation plan yet.
Right. No, I know that, and I do recall the last procurement, but it is a concern, and I realize that we don't know yet because it's not being implemented, and that's, I must say that that's the problem about approving a vendor before we know anything, which, has been an ongoing issue, not with GIC, but it's, the procurement process. It makes it very difficult to say yes without having answers to all that questions.
I will say, Madam Vice Chair, and to other members of the commission, that there's a lot more work than 4 slides really does credit for here by the strategic sourcing team. While the details of implementation, some of which you note here being, challenging to communicate to our members, part of our evaluation of vendors includes their capabilities around managing this sort of a transition. So while we don't go into great detail here about those capabilities, I'm very confident that we've evaluated their capabilities throughout this procurement, and that comfort level is an important part of why we are presenting this to you today, right? There's a lot more that goes into the procurement from the SST than we're able to get into in detail with the commission. So your comments are well taken. We're gonna, and many of these issues, I venture to say all of these issues are very much on our radar, and we will be digging into them in greater detail in the coming months.
Yeah.
Thank you,
Anytime
Matt.
we're implementing a new vendor or carrier, communication is always a critical component for the membership. So it is very much front of mind for all of us.
Thank you, Cameron. And certainly I'm not, questioning at all the expertise and professionalism and knowledge that GIC staff has. I'm very much aware of that and appreciate the hard work that they do. This is not easy process, but I do have to express my concerns regardless, because I'm representing, quite a few, more than 10,000 people, close to 20. And so it is a concern. I know how it worked in the past. I've been doing this for a while, and I have to raise those issues. So, I appreciate, Matt, what you have said, and also Cameron for the presentation.
Any other questions, Bobby? I certainly hear your concerns, and it sounds like the staff as well. If there isn't any other discussion specific to determining the process to get to this point where the recommendation is to bring on Task as our new FSA provider, I will entertain a motion now to approve Task as the apparent successful bidder to provide FSA services in 2024, fiscal year 24.
So moved.
So I have a motion, a second.
Second.
Okay, couple of seconds. Thank you. So at this point, my vote is aye, and I'll turn it over to Andrew to do roll call for each commissioner.
Thank you. Vice Chair Kaplan,
Aye.
Designee Roder,
Aye.
Designee Butler,
Aye.
Commissioner Shabbat,
Aye.
Commissioner Chapdelaine,
Yes.
Commissioner Choate,
Yes.
Commissioner Clenard,
Yes.
Commissioner Davis,
Aye.
Commissioner Edmonds,
Aye.
Commissioner Gentile,
Yes.
Commissioner Guerin.
Yeah.
Commissioner McEnany,
Yes.
Commissioner Sinenko,
Yes.
and Commissioner Sullivan.
Yes.
The motion is approved.
Yeah, great. Thank you. Thank you, everyone. And thank you to Cameron and for your team. And, please do note the importance of our members and, the implementation that's needed to ensure, tight communications. It's people's money, and, making sure that they are able to use the funds appropriately, I think is what Bobby was asking for, that attention to detail. So thank you. Let's move on to the next order of business.
Terrific. Thank you, Madam Chair, members of the commission. As you know, so we'll move on to the FY24 medical benefit procurement. As you know, we have been collectively hard at work for well over a year in order to present you with this recommendation for coverage starting on July 1st, 2023. By way of quick recap, early on, working with you commissioners, we developed a strategic framework built around our three priorities of affordability, behavioral health access, and health equity. We further explored the challenges and opportunities that we face in making progress in each of these areas. We also engaged with a wide variety of stakeholders to better understand their perspectives and to educate ourselves about the emerging and current dynamics in the Massachusetts healthcare marketplace. And this all allowed us to gather information to determine the best steps that we can take through the procurement for sure, but also beyond, to provide greater value to our members and to the Commonwealth. So guided by the commission and all that we've learned, we released our RFR on April 1st and have spent the last several months evaluating responses in order to present you with this recommendation today. As doing that, we put a great deal of thought to ensure that commissioners were well informed and had the time and materials necessary to vote on the recommendation today. And in doing that, we've relied heavily on your commitment to abide by the constraints imposed by the procurement rules and relatedly through the confidentiality agreements. We acknowledge that these constraints can be challenging, but operating within these constraints is really necessary and ensures that we can successfully execute contracts with our selected vendors. So thank you for your cooperation in that regard. With this recommendation, we sought to balance progress on our strategic priorities with the potential for implementation risks and member disruption. And I can say as executive director without reservation that the recommendation that the team presents to you today is a responsible, balanced, and successful one. And it positions the GIC well to make progress towards our strategic objectives over the coming years. You can also be confident that the procurement was handled in accordance with the rules and regulations that govern this process. So two brief housekeeping items for today's presentation. As you know, we've talked about it several times over the last year. Harvard Pilgrim and Tufts merged to form Point 32. Point 32 submitted one combined bid that will continue, but they will continue to use brand names for Harvard Pilgrim for their commercial offerings and Tufts for the Medicare Advantage offerings. And that's how they bid through the process. You will see throughout the presentation that we've reflected this by noting point 32 in parentheses under each of those two brand names. Additionally, in the coming months, Always Health Partners will be undergoing a name change to Mass General Brigham Health Plan. Again, for the purposes and for simplicity in this presentation, we will refer to that entity as Always, as that is how they submitted their bid in response to the RFR. So before handing it over to Jim Rust, our CFO and Chief Procurement Officer, I want to thank our external stakeholders and colleagues in state government with whom we met frequently throughout this process. I want to thank the hardworking team at WTW that continues to serve us very well. And of course, you, our GIC commissioners, for your wisdom and guidance. I also want to give a big thanks to the GIC staff, in particular the strategic sourcing team, for the tremendous effort that was put into developing this recommendation. Their professionalism, dedication to our mission, and willingness to work hard and collaboratively together makes me really proud, and I hope it makes you all proud. And lastly, I just want to give a special thanks and acknowledgement to Jim Rust. In addition to all of his work as our CFO on the finance side, we have relied heavily on him and his team throughout this process to manage a complex set of work streams and to stay on our timeline. Jim is an outstanding colleague and manager of people, and he provides an enormous service to this agency, to our members, and to the Commonwealth. So with that, I will hand it over to Jim to introduce the team and the topic.
Thank you, Matt. The team and I really appreciate the support. I'm going to provide a brief refresher on the process and timeline of this procurement. So if we can move to the next slide, please. This has been a long and detailed process, as you all know, spanning much of the year. This process is measured not even in months, but in seasons. You may recall from our meetings in the late winter into early spring, we discussed a number of areas of focus and guiding principles for this procurement prior to the drafting of the RFR document itself. And then in April, as we informed you at that meeting, we released the RFR on ComBuys, which is the Commonwealth's procurement platform. And then shortly before summer arrived, interested parties responded to the RFR. We vetted those responses as responsive to the RFR and meeting our threshold requirements. And then over the course of the summer, we evaluated and scored the proposals. Our partners at WTW performed a detailed technical and financial analysis, and the GIC team members scored the respondents on their answers to a variety of questions, which resulted in a round of best and final offers, and ultimately the results that Cameron will walk us through momentarily. Now in the middle of the fall, we're presenting recommendations for a vote. Ultimately, the resulting contracts will go into effect, in the summer of 2023. Next slide, please. I should mention, stay on this slide, please, but I should mention we did have a cross-organizational team, folks from legal, folks from data analytics, as well as management staff on this procurement team, as Cameron will also mention. And as Matt mentioned during his introduction, and as described on this slide, the RFR process focused on 3 priority areas: affordability, behavioral health, and health equity, and was guided by member-focused principles to leverage the GIC's buying power to the benefit of members, while also managing and balancing member disruption and implementation risks. I will now turn the presentation over to Cameron McBean to walk us through the responses, results, and recommendations. Cameron is the project lead for this procurement. He did excellent work managing this process, herding all the cats and keeping this procurement on point and on time. Cameron, if you want to take it from here.
Thank you, Jim. Thank you once again, commissioners. If we could move on to the next slide. We are going to begin by focusing on the active and non-Medicare plans, and then we will move to the Medicare plans. But we want to begin by refreshing everyone's memory on the current state of the medical plan portfolio. On the commercial side, we work with Always, who, as Matt mentioned, will be changing their name next year in 2023 to Mass General Brigham Health Plan, Health New England, Harvard, Pilgrim, and Tufts, who have since merged into Point 32, and Unicare. Between them, there are 9 separate medical plans for active members to choose from. Each carrier, other than Always, also offers a Medicare supplement plan to our members, and Tufts also offers a Medicare Advantage HMO plan to Massachusetts Medicare participants. Next slide, please. So focusing on the active and non-Medicare population first, we received bids from all of our incumbent vendors, as well as a proposal from Aetna. And just as with the FSA plan, all bidders were first evaluated based on their supplier diversity proposals, their technical proposals, cost proposals, and their responses to our written essay questions. In the case of the active plan submissions, all bidders ended up being selected as finalists. If we could please move on to the next slide. We put this slide together to illustrate the impact that the administrative services fees, the ASO fees, that we pay on a per employee per month member to our insurance carrier partners. We wanted to illustrate just how relatively little impact it has on the overall cost of a plan. It makes up, on average, about 5% of the total expense for a medical plan. Now, it is one of the few fixed costs that we have to evaluate during the bidding evaluation process. So it may appear to have an outsized impact when reviewing the details of the recommendation memo. But we just wanted to illustrate that, overall, it is not necessarily a significant contributor to our medical spend. Next slide, please. So this is an illustration of the relative breakdown of the scoring results in response to this procurement. Harvard Pilgrim, which is the brand name that Point 32 is using for all of their commercial products. So anyone who is an active or non-Medicare participant will have a Harvard Pilgrim plan in the new contract cycle, as well as their Medicare supplement plan will also be branded as Harvard Pilgrim. Unicare came in second. Health New England ended up right in the middle. Always was a little bit below Health New England in the final reckoning, and Aetna unfortunately came in last place on it from a ranking perspective. We can move on to the next slide, please. We're going to get into the rationale for these recommendations here in just a moment with a little bit further detail from Margaret Anschutz. But the recommendation that we're making is that we contract with all of our current carriers, not going with a new active plan supplied by Aetna, but we are proposing some changes. The first change, and most significant, will be that we intend to replace coverage for residents outside of New England. Currently, Unicare Basic is our only true nationwide plan because it has no network restrictions. The proposal that was submitted from Harvard Pilgrim, which includes utilization of United Healthcare's nationwide network, we felt is a better solution for members outside of the New England area. We're also proposing to reclassify Always as a broad network plan to better align it with the GIC's tiering approach for similarly positioned vendors. We can move on to the next slide, please. With respect to GIC's strategic priorities of affordability, health equity, and behavioral health, all of the incumbent and proposed carriers committed to working with us to achieve our goals. Affordability and cost will remain a driving concern for the GIC, and we will continue to evaluate any strategies to address the issue that our carriers can provide. The challenge on health equity is that we and the carriers are still in the early stages of gathering data on our members so that we and they can define, identify, and understand the problems of access and equity that can then be addressed. Behavioral health's main challenge for the GIC and all residents of the Commonwealth remains one of access. All our carriers expressed a commitment to complying with the EHS Behavioral Health Roadmap, and both Harvard Pilgrim and Always will be creating their own in-house behavioral health networks rather than carving out those services to a subcontractor, with the hope that this leads to improved coordination and member experience. Commissioner Kaplan, I see you have a question. You may be on mute.
Sorry. How many active members live outside of Massachusetts?
Approximately 4,200.
That's active, not retirees.
Members who are currently in the basic plan with a zip code outside of New England. Yes.
Okay. All right. So so their insurance will be changed, or their carrier. Right?
Yes. And Margaret will be getting into the details of why we're making this proposal on the next slide, talking about the cost savings for both the Commonwealth and for members that we anticipate.
Well, aside from the cost savings, so will Margaret be speaking to the changes, if there are changes, the two providers?
We did do we
Oh.
did perform a disruption analysis, or actually Willis Towers Watson performed an initial disruption analysis, which is why we feel very confident in making this recommendation. So with that, I'm actually going to suggest we move on to the next slide, and I'll hand things over to Margaret to get into those details in a little bit
Okay.
more depth.
I'll reserve my questions for her.
Okay. Commissioner Edwards, did you have a question?
It's Edmonds.
Edmonds, I'm sorry.
On the health equity, some of the bullet points strike me as vague. Do you have any more information about when there will be, for example, the agreement to collect race and ethnicity data to support stratified reporting on clinical measures? When will that happen?
That is hard to give a firm answer to, unfortunately. There are considerations as to who is best positioned to collect that data.
Hey, Cameron,
Yes.
why don't we kick that over to Margaret, who's been spending a good deal of time on this.
Thank
If I
you.
may,
Thank you.
I could add another question. Thoughtful solutions. I'm having difficulty with that phrasing, and wonder why it's not effective solutions.
Yeah,
Okay.
fair question.
Yeah.
So regarding the data collection, one of the specific requirements we put in the RFR was that all of our carriers would comply with the state standards for race, ethnicity, and language collection for the data. Where the state is with defining those standards, they are, I think, within 6 months of having the standards, and then from there, all of our carriers agreed to implementing, our definitions so that we can compare apples to apples in the data. From there, it's going to take, I think, really an active enrollment for the GIC to collect 100% of our population's race ethnicity data. Beyond that, a number of our carriers have imputed data, which is certainly better than nothing, but we really want self-reported data. In terms of maternal health, that is it is vague on the slide. The approach is, there are some carriers are are using doulas at birthing centers, which has been shown to great effect. Beyond that, maternal health, reporting on maternal health is part of the NCQA accreditation in health equity, which again, we also wrote that into the RFR, that all of our carriers will have to seek accreditation. And what that means is, again, it reinforces the need and the requirement to collect race ethnicity data. And the carriers have a few places that they can collect it where we are dependent on an active enrollment. And then they also have, along with the health equity accreditation, is the ability and requirement to stratify quality metrics, such as maternal health related metrics in the reporting. And so we would be requiring that of our carriers, and that would be a regular part of the reporting cycle with them. And so what we hope to see from that is evidence-based interventions that drive down the disparities in care.
Thank you for that. Again, what I was trying to understand is that the commitment is real and it's active and it's focused and it's specific. And it's not a check the box exercise.
Yeah,
and that's what I'm trying to figure out, because we're talking about human beings.
Absolutely.
And so that my question is really intended to say that if you're a vendor to demonstrate a focus on health equity, then it should be very clear, specific, focused, and give us an ability to measure the effectiveness of whatever is done. And that's really where my question is coming from. But I appreciate your answer. Thank you so much.
Yeah.
And so,
yes, Commissioner.
Margaret?
Yes.
So one potential thought to discuss with the carriers as if we approve this approach and you move into contracting, could you request some, financial penalties for carriers who, fall short of collecting this data, fall short of driving outcomes, measurable outcomes in maternal health within, unequal populations? Or we should improve maternal health everywhere, but certainly, what's been the focus in communities where, there's definitely a gap. Is there any consideration, can Andrew put his, good negotiating hat on to, really get some effective measurement in place to show the carriers that, we mean business here?
I think that's right. And that has to happen. And we have a number of performance guarantees already in place. I do anticipate that health equity specific performance guarantees will be in place, but the first thing that has to happen is everyone has to have data. I think the commission understands that. So we get the data in place. We expect to see reductions in the disparities, and we want to see these interventions and the data operationalized as part of their population health strategy. I think that's what we're saying, and we want reporting, and that's how we hold people accountable.
I hear you, but maybe a KPI can be, X% improvement in their data, and if not, there's a financial penalty. That's where I'm going with, because we do need the data.
Absolutely.
And without it, we can't move forward. And you've been a huge champion of the data, so thank you. Mm-hmm. Does that help, Jane? Is that helpful? Good conversation.
It's helpful, but very honestly, my continued frustration is that we shouldn't be in a conversation now trying to have data pertaining to race and ethnicity. It just strikes me as irresponsible for us as a government system to not have that information in hand. We're all human beings and we all deserve to have that kind of data available. So it's a troubling thing, and I understand the scope and difficulty in getting the data, but at the same time, as Dr. Martin Luther King Jr. said in his famous letter to Birmingham jail, to wait for certain things to occur is just very difficult, if not impossible, for me to feel comfortable with. So I yield to Bobby.
Oh, no. I just wanted to add to what Commissioner Edmonds is saying, that we've been talking about this now for a couple of years. And it's very difficult to make a decision, right, without having enough information, particularly, you know, there have been so many articles in the last, I don't know how many months, you know, months and months, if not years, regarding, you know, maternal health, right? Regarding women's health. It's very, you know, disturbing, and it's not about GIC, it's about the data. Like, how are we going to, when are we going to get it? You know, does this mean another, you know, year and a half, right? Another full fiscal year before we have any information? It's
So
you know, like,
if I may briefly, and actually say a comment about the procurement and how it generally relates to our three strategic priorities as we've laid them out here. The procurement allows us to select vendors, which really lays a firm foundation for much more concrete and specific work that we will develop and lay out in more detail. But the procurement for us is not, and I think I've said this before, it's not the only tool for us. And in some respects, it's not the most, it's not the opportunity for us to make the most important concrete specific decisions, right? We are selecting vendors based on their capabilities, based on their commitments. And once we have those in place, based on evaluations of those dimensions, we then can move to the next step, which is much more detailed work. We've talked a little bit here today about key performance indicators and financial guarantees that we can use to hold the carriers accountable. And that is all work that we have ongoing, and we will continue to lean into after the procurement and we have our vendors. But I just want to make sure that folks understand that essentially what we're doing here is laying the foundation through our vendors for work that's going forward. I hope that kind of makes sense a little bit here. So these are all fantastic questions, and we are thinking them through every day. We've thought them through in detail through the procurement, but there is still so much more work on these that lies ahead. What I think I'm hearing from the commission that I've heard throughout our conversations, particularly around health equity, is a real urgency for action, and we share that. And so I hope that's helpful, just to provide a little bit of framing on how procurement fits into this process.
And I want to add to that one concrete example is that we are doing a GIC specific focus on maternal health. And we're working with Willis Towers Watson, who has led another group through this kind of intervention. And we don't have the data, but I don't see that as a reason to not focus on where we know there are disparities. I have no reason to believe our population is different from the national population. We know where those disparities are, and so we're moving on those.
thank you. Very glad to hear that.
Yeah, and we want to hear updates as you do more and get the data and show outcomes. So thank you. So I think we can move on. I don't see any other questions. That's good discussion. So thanks for bringing up your concerns, Jane and Bobby. Appreciate that. But let's move on.
I think we should advance the next,
Great. I think this is my slide. All right, so while we stayed with our incumbent vendors, we also made a couple of important product changes. First, our national plan. Our national plan has been Unicare Basic, which served out of area members, including many in the non-Medicare eligible population. When comparing Basic with the Harvard Pilgrim national product, it was clear that Harvard Pilgrim offered great value to the GIC and our members. Specifically, Harvard's network has a better fee schedule outside of the New England area than does Unicare, with projected savings of at least $9 million annually. There should be minimal provider disruption, as roughly 97% of last fiscal year's claims under Basic would still be in network with Harvard Pilgrim. And finally, Harvard Pilgrim's ASO fees are significantly lower than Unicare's. The second portfolio change is with Always. This carrier is moving from a regional classification, which has lower associated copays, to a broad classification. And here's the rationale. The Always member service area will now cover nearly all of the state, and so is by definition a broad network plan. Broad network plans are all subject to tiering. This is where there will be changes for current Always members. Not designating Always as a broad plan would give them an unfair competitive advantage against the other broad plans. The advantage being the ability to draw membership from across the state without the cost sharing checks on the highest priced facilities. We also examined the data, and we've seen that Always inpatient rates are at the highest cost facilities in the Commonwealth are considerably higher than other carrier rates at the same facility, making it all the more important to implement tiering to steer and signal value. And I'm happy to take some questions on this slide.
Margaret?
So,
Oh, go ahead, Bobby.
So with Always, they're going to be transitioning to, or they're going to be renaming themselves. Is that going to be July 1st? Do you know? Is that going to be when, the new fiscal year? Is it going to be like mid-year or something like that? Do you have any idea?
I'm going to look to Cameron for that. Yeah.
Yes, their name change becomes official January 1st. They're going to continue with regards to GIC members to utilize Always, but inform everyone of the name change. So we won't be issuing new ID cards for the first half of calendar year 2023. So the current Always cards will continue to work. There will be lots of notices on Always website, and including on the GIC microsite, notifying everyone of the new change. But we will be using the new plan change, for fiscal 24 and within the benefit decision guides. And it will be yet another exercise in messaging and communication to let our members know.
Right. And I imagine particularly for those who are using, who currently might use, Mass General Brigham providers, right? Like, it's confusing because it will be Mass General Brigham plan. And so that's pretty confusing, I think, to people who currently see Mass General Brigham, through different carriers, right? It's confusing, like, to explain that, I think. So we want to make sure the communications are clear enough, at least from, from Always, not only to the current members, but how is that going to be communicated to members who are, who subscribe to different carriers? You know what I mean? I don't know if I'm being clear enough in my question, but it's so confusing.
I understand the point you're making. We will try and take that into consideration and, distinguish that this is an insurance carrier and a health insurance plan. It is not the only way that you can see Mass General providers. Okay.
And I have another question regarding Harvard Pilgrim as the national plan. So when you talk about $9 million in sort of savings, I guess, like, Are there savings for members?
Yeah, that's a good question. So, premiums, I would say, I think everyone on the commission understands, reflects the price and the utilization of our membership. And so when you bring the price down by $9 million annually, that then, it's a savings over a $9 million annual savings over what it would have been with Unicare Basic. And so, I do think the healthcare market right now is inflationary, like everywhere else, but you can think of this as like a move to the Harvard Pilgrim National product as being $9 million that would go towards premium reduction. That's spread out across the population through the premiums.
Well, I hope so. I mean, I hope there are savings to members, which is, I get it. It's great that there are savings to GIC, but if there are funds remaining, it, goes back to the, general fund. So what is the savings to members? It's my, concern.
Yeah, and then Margaret, you have here a 30% premium reduction. So I'm reading that, tell me if I'm wrong, to Bobby's question, the thinking will be that our members who enroll in this national plan will save 30% on their premiums. Is that an accurate view?
That's the projection, but I want to be clear that there's still a lot of inflation in the healthcare market. So I don't want to say it's 30% off the last fiscal year's premiums, because we're going to see an increase. But yes, if we took if we took basic versus Harvard Pilgrim and did a rate analysis, we would expect Harvard Pilgrim to be significantly cheaper.
Right, significantly cheaper, but not necessarily a savings to members. Right?
Well,
I mean, in reality, because of inflation, right? So, people are not going to see 30% reduction in their premium, I would assume.
That is a very important point to understand. Yes, because of how much we're increasing in the healthcare market. Yeah.
Right. So it's just a comparison between two providers, really, or two carriers, I should say. Right? It's not about the members. So I want to be pretty clear about that, because when you read it, it looks great, 30% reduction, but it really is not to members. I don't want anyone thinking that, wow, I'm going to pay 30% less next year.
No, yes, but Bobby, what I think Margaret's saying is what the thinking based on the proposal is members will pay less with this plan. It will personally save them more money than if we stayed with Unicare. Is that inaccurate? Yeah,
I understand that.
It's just not clear. We vote on the rates once we negotiate with the plan. So we're getting a little bit ahead. Your point is well taken. It does seem like what I'm reading from the procurement output is the thinking was based on what's important to the members and trying to give them the savings that will help them live better lives, as well as the GIC saves. So
I get it, right? I get it, Valerie. It's just that I just want to be clear for, people who are, I don't want anyone to walk away thinking that they're going to be paying 30% less on their premium than they currently are.
Yes, I think you said that very well, loud and clear.
Yes, I'm saying it again.
Thank you. So, hey, Anna, I see you have your hand up.
Yeah, thank you. I think this is a really important conversation. I think just remarking on the fact of moving to a national plan with improved provider discounts should mean less overall spending in this plan relative to the alternative. And so there's sort of two, I just wanted to add to the conversation that there's this question of, well, how much maybe direct savings you're going to get right away, and that's unknown. But if we spend less in this plan, that's a benefit to all of us, including the members. because then the GIC budget doesn't have to be as big. Massachusetts doesn't have to raise as much tax revenue to fund the benefits. And so that's sort of an indirect benefit, but a benefit nonetheless of moving to a lower cost or a lower spending plan. So there's that benefit too.
Thanks, Anna. That's a good health economics perspective.
Right.
I don't. Yeah.
Thank you.
Good. Yeah. I don't see any other questions. I was going to just ask briefly about the 17,000 members. Is that specific to Always or across the three that are listed here as our broad network?
There are 17,000. Yeah, 17,000 members enrolled in Always today. That's not subscribers, that's total members. And so we will be communicating with them.
Okay, great. I don't see any other questions, so we can keep moving. It's a good conversation.
Okay, and very briefly before we move on to Medicare, I wanted to correct a slight misstatement I made earlier. Always, as part of the rebranding exercise to Mass General Brigham, will be communicating with our GIC members and issuing them new ID cards in December, which will be effective in January. This is because they have been communicating with their provider network for several months about the name change, and they want to make sure that our members get their claims processed appropriately. The user ID or the unique subscriber ID numbers, I believe, should all remain the same. But I just wanted to correct that misstatement from a few minutes ago. So before moving on, as we move on to Medicare, we did receive bids from all of our current carrier partners, as well as Fallon Health, who proposed another local Medicare Advantage plan, as well as national Medicare Advantage products from both Aetna and United Healthcare. Next slide, please. So once again, we're illustrating the relative positioning upon evaluation of all the scores from the bidders. For our Medicare supplement plans, Health New England had the highest score. Harvard Pilgrim, who again is the brand for 0.32 for any Medicare supplement plan, and then Unicare, which is our largest Medicare supplement plan by far in terms of enrollment. We received proposals from Tufts to renew their Medicare Advantage plan, as well as Medicare Advantage offerings from both Fallon and Health New England. And then on the national Medicare Advantage plan, again, you see that Aetna's was ranked significantly higher than United Healthcare. Next slide, please. It should be noted that neither Fallon nor United Healthcare made it to the finalist stage. So now we want to review our final recommendation, and that is that we enter into contract negotiations with all of our current vendors. We did have a strong and in-depth look at the Medicare Advantage proposal that was put forth by Aetna for either full or partial replacement for our Medicare populace. But there were significant concerns from an operational standpoint as to whether or not we could ensure not only a smooth transition during implementation, but also on an ongoing basis because of the interaction between the Federal Center for Medicare Services and our operational capabilities. It's something we may revisit in the future or during future procurements, because at this point in time, there are substantial savings, but we did not feel it was worth the risk for our substantial Medicare populace to possibly place them at risk of either gaps or loss of coverage. Any questions with regards to the Medicare recommendations?
Do you have any idea about cost? Or we'll get into that more, but wondering if the impact that we saw in the active and non-Medicare with some savings and some premium suggestions, if there's any savings here for renewal with all these vendors.
I wouldn't say that there are significant savings. So much of the costs associated with our Medicare plans are shouldered by the federal government because they've got primary responsibility for inpatient costs. So there is not as much variation and impact to be found on the Medicare plans.
Okay.
I will note here that the Center for Medicare and Medicaid Services at the federal level has, to Cameron's point about Medicare being the primary payer for these services, there are some actual reductions in Part B premiums, which I think is reflective generally of the federal government's assessment of trend within Medicare plans. I won't make any statements about what that means for us, but I think it is a good, more global fact to acknowledge here about the future of Medicare spending.
Okay. Very good. Thank you. I don't see any questions. You can keep moving.
Okay, next slide, please. With this, I'm going to hand things back over to Andrew Stern, our General Counsel. He'll touch a little bit on the contracting process and next steps. Thank you.
Thank you, Cameron. As a reminder, all procurement votes are choosing apparent successful bidders. That includes the FSA one we had earlier and the coming vote and the ones that will be coming in following meetings. This recognizes that the procurement is not over until we have a signed contract. And it's always possible that we might be not able to achieve a successful contract with the first choice. Implicit in your vote is authorization for us in the event this occurs to try to contract with the next best bidder when it's appropriate. With respect to the current procurement, the health carrier procurement, after you've chosen the slate of vendors, we'll begin the contracting process, which can take months. Simultaneous with our contracting efforts, we'll be working on product design, which we'll be bringing back to you at the January meeting. We will also begin the rate development process, and you'll get the preliminary rates, and then final rates will have to be finalized by the end of February. Additionally, and simultaneously, we'll be working on all implementation activities with any new vendors and products. The consolidation will change that. Will be at point 32. Vendor handbooks will all have to be redone, and all material for annual enrollment will have to be started so that it can be completed in time for April's annual enrollment. So that's the landscape that we'll be operating in as we move forward. And then, of course, as Erica already mentioned, there's also the listening sessions that we have to be prepared for that will be happening in January. I think we can move on to the vote at this point, unless there are questions.
No, lots of work anticipated. I think that's what your summary is, Andrew. We've got lots of work ahead of us, and this is the beginning point. So I don't see another question. So at this time, I will entertain two motions. Can we put them together, Andrew?
Yeah.
Motion one and motion two? Okay. So motion to, subject to executing contracts I have a motion. I'm looking for a motion that we agree with the choice of Unicare Point 32, Health New England, and Always Health Partners as apparent successful bidders for the administration of medical and behavioral health benefits for our commercial, which are non-Medicare members. And then additionally, also subject to successful contracting, we affirm the choice of Unicare Point 32 and Health New England as the successful bidders for admin of Medicare supplemental plans and Point 32 for local Med Advantage plan.
So moved.
Do I have a motion?
So
Okay,
moved.
by Tamara.
Yes.
Nice to see you. And do I have a second?
I'll second.
Okay, Bobby second. So I approve of this. Yay, yes. And at this point, I'll put it over to Andrew to do roll call.
Thank you. Vice Chair Kaplan,
Yes.
Designee Roder,
Yes.
Designee Butler,
Yes.
Commissioner Shabbat,
Yes.
Commissioner Chapdelaine,
Yes.
Commissioner Choate,
Yes.
Commissioner Kleinard,
Yes.
Commissioner Davis,
Yes.
Commissioner Edmonds,
Yes.
Commissioner Gentile,
Yes.
Commissioner Garand,
Yes.
Commissioner McEnany,
Yes.
Commissioner Sineko,
Yes.
and Commissioner Sullivan.
Yes.
The vote passes unanimously.
Oh, well, thank you. Thank you, commissioners. I know there's a lot of work that's been done to get up to speed on this, and really good work by the GIC, by the team. I'm really excited about this go forward path. And, also want to thank Willis Towers Watson for their counsel and support. So nice outcome here. It's not the end, it's just the beginning though, as Andrew so eloquently reminded us. So go forth and contract and get those KPIs in that really hold the plan accountable to our three imperatives in a meaningful way. It's not just to check the box, but we're serious about affordability, health equity, and behavioral health.
Thank you, Madam Chair. Thank you, members of the commission. On behalf of the staff, really grateful for the confidence that you've put in us to make these important decisions. I think, as the chair just said, and we've noted several times throughout this meeting, we acknowledge there's a lot more work to do. A lot of it is underway. As it relates to this procurement, many months of work ahead to ensure that we have a smooth transition for our members. But I have every confidence in this team that we will do that. So really grateful for the confidence of the commission with that vote.
Well, it's been a thoughtful process. I do believe you've led the team very thoughtfully and with good data. So looking forward to hearing more at the next meeting that we have scheduled. I know there's more work to do for sure. At this point, I don't know if there's any other business. If you want to move on, Matt, I think this was the last agenda item. Do commissioners have some discussion points to bring up?
I have a question, Toby Choate.
Hi, Toby.
Which is, I don't know if this will be a popular or unpopular question, but what's the status on having in-person meetings again?
Yeah, so thank you for that question. We've had extensive discussions with the chair and the vice chair on this topic. We don't have firm details to share at this point, but I can tell you that early in 2023, depending on how the course of the pandemic continues, we would be looking to reintroduce some portion of in-person meetings. So I think we're all eager to do that. Ever mindful, of course, that the pandemic has not been a straight line path, but many bobs and weaves, so we can't predict the future there, but our intent is to reintroduce some version of in-person meetings early in 2023.
Okay, thank you.
Bobby, I see you have your hand up. Do you have a question?
Well, I just wanted to, first of all, comment that I would love to see that in-person meetings like January, providing there were no great surges in the pandemic or major snowstorms, that maybe we could do that. But I had a question regarding, would we be able to do both? Like, I guess as long as we had a quorum physically, that we could, if one of or two more of the commissioners are unable to be here, physically, if they could then be virtual. Like, I guess maybe that question is to Andrew. Would that be a problem if we're not all in the same place?
Currently, we are still operating under the pandemic exceptions to the open meeting law. There is been some movement to codify some new rules, but under those exceptions, we could do what you're asking. If we revert to the old rules, it could become problematic, but we would need to be streaming still. That's the biggest holdup.
Okay, so we could do both, right? Have some commissioners sort of together physically, and then have others, virtual. Is that? But is that the exception? Does that expire in March?
So our Deputy Executive Director, Erica Shabelli, has been doing some work on this too. Erica, if you want to chime in.
Sure. So at the moment, yes, it expires in March. And we would be able to do hybrid, assuming that we can get the appropriate technology together to do that and an actual space to do that. So those are all logistics that Chief of Staff Emily Williams and I and others have been looking into, anticipating an early 2023 kind of hybrid restart. So that kind of information gathering is ongoing. As you probably know, a lot of the spaces that we would typically use are not open and available to us. And those that are don't always have the appropriate streaming capabilities and technology that we would need. So there are some logistics to continue to figure out, but it is something that Emily and I have been working on and trying to figure out our next steps forward so that we can make that hybrid piece happen. As Andrew noted, if that exemption expires and is not renewed in March, we would have to then figure out kind of additional next steps we could take for hybrid or kind of phone call participation, which typically requires a quorum, a physical quorum for each meeting. So we will cross that bridge when we come to it, but for early 2023, we are well into the process of figuring out what our next steps are in terms of logistics.
Oh, that's great news. I'm happy there's a possibility. Anyway,
Yeah.
that's great.
We're trying.
Thank you. Thank you. I'm sure
Yeah.
you are. It's very difficult
Yeah.
because of the space constraints and,
Yes.
Yeah,
I don't want to
so thank
understate
you.
the complexity of pulling this off, but we are, as Erica noted, giving a lot of thought. I would say that, for those commissioners who haven't spoken on this topic, and if you have thoughts on this, please reach out to me, and we're happy to add that to our thinking and planning.
Yeah, I think that's great.
We want to be able to do this in a way that works for everybody.
Yeah. Well, I, for one, am in favor of at least getting together with commissioners in person. I do miss seeing everybody And, I think it's the camaraderie that is equally important to our expertise advising the staff that makes being a commissioner a valued resource and a good experience. So looking forward to seeing everyone, although I can see most of you in your little boxes. I'd like to see you all in person. But until that time, unless there's no other business, I'm going to adjourn this meeting and wish you a beautiful fall, late October day. And we will see you in November. And thanks for your hard work, GIC. I know it continues. And we'll look forward to hearing the progress on these contracts. Bye,
Thanks.
everyone.
Bye, everyone.
Thank you all.
Bye.
Thank you.
Bye.